starting from the beginning, the ear begins development at the very earliest stages. The inner ear starts development at the 3rd week after conception. And the inner ear itself goes on to continue development through the 25th week. When we talk about the ear anatomy, it's essentially broken up into 3 basic parts. There's the outer ear. It's composed of the auricle or the pinna, which is the cartilaginous funnel, which helps bring sound waves and pressure waves into the ear canal. The ear canal is made up of a soft outer cartilaginous portion and a bony, more medial or inner part to the ear canal. That's the external ear. And that funnels the sound waves to the eardrum, which is part of the middle ear, which is the second part of the ear. And the middle ear is the eardrum and the 3 hearing bones, the malleus, the incus, and the stapes. And those little hearing bones are encased within the middle ear space, which is that red portion there, which is actually part of the respiratory system. And that red space, the middle ear, is connected to the top of the throat, the back of the nose, through the eustachian tube. The eustachian tube is what allows us to equalize pressure when the pressure changes around us. And that's where ear infections, ear fluid all comes in, because the middle ear is actually encased with within the respiratory system. It's made up of cells that create mucus, and that mucus is supposed to drain out of the middle ear into the throat. The inner ear is actually composed of the cochlea, which is the inner ear hearing organ. The inner ear is also composed of a very important part of the balance organ, which is the semicircular canals and the utricle and the saccule, which help us maintain a sense of equilibrium. So how does hearing work? The external ear and the ear canal helps funnel the sound waves, the pressure waves, into the ear canal to the eardrum. When the sound waves hit the eardrum vibrates. And that vibration of the eardrum actually causes those 3 hearing bones, the malleus, the incus, and the stapes, to move relative to one another. And the middle ear, inner ear also, but the middle ear, its most important role really is amplifying noise. And they send that pressure wave to the inner ear from an air pressure wave to a fluid wave, which is the inner ear. So that stapes works as a piston with that sound wave, and it moves the fluid within the inner ear. It creates a wave in the inner ear, and that fluid moves through the cochlea. And based on the pitch or the frequency and the loudness, different cells within the cochlea get turned on. And those are called the hair cells. They twitch and they release little molecules and ions into their cell bodies, which creates an electrical impulse which turns on the nerve, which sends the sound to the brain. So we have to have a normal external ear. We have to have a normal outer ear to help funnel noise, ear canal, eardrum, middle ear with the hearing bones, and a normal inner ear, a normal nerve, and a normal brain to have good hearing. So the first type of hearing loss is conductive hearing loss. Children with ear tubes, children with atresia, that's predominantly the type of hearing loss we're dealing with. Conductive hearing loss is when there's an interruption in that sound wave through the air from the outside world to the inner ear. So basically we're talking about problems in the anatomy of the ear canal, eardrum, middle ear, hearing bones. For example, earwax. You get a big plug of earwax, the sound is muffled. It's a problem in the conduction of sound to the inner ear. That's a conductive hearing loss. Otitis media, the classic middle ear infection that toddlers get, is when the fluid builds up, or the mucus builds up in that middle ear space because the eustachian tube isn't allowing the fluid out. An absent ear canal, a hole in the eardrum. A cholesteatoma is a very problematic tumor that can grow in the ears of kids who have had cleft palate, a lot of ear infections, problems with their eustachian tube, unable to clear the pressure in the ear very well, and certainly any kind of trauma, Q-tip in the ear, or a fracture in the skull that disrupts the way the hearing bones and eardrum function relative to one another. The next major type of hearing loss is sensorineural hearing loss. Infection in pregnancy. I always tell you, if you have a cat, wash your hands, stay away from the litter box. Toxoplasma is a microorganism that can be spread through cat feces. If a pregnant woman or a pregnant mother develops an infection with that type of bacteria, it can affect the developing fetus in the very early stages and cause a nerve-type hearing loss. A very ubiquitous or common infection that we see throughout the population is caused by a virus known as the cytomegalovirus. It causes a fever, upper respiratory type infection symptoms, and can cause deafness in a developing fetus and in an infant. Prematurity. Babies who are born at that 25-week gestation period or below. Extreme prematurity, extended stay in the neonatal ICU, extended amount of time on an artificial ventilator, severe jaundice, certain medications, particularly intravenous antibiotics that we sometimes use in very small premature babies who might develop an infection in the hospital, certain diuretics, even aspirin can cause hearing loss. Meningitis is a bacterial infection of the lining around the brain, can basically attack the inner ear and cause the inner ear to develop severe inflammation that affects the hearing and can cause deafness. And of course, noise exposure. And then the next type of sensorineural hearing loss that's caused by some kind of genetic abnormality, something that may or may not be inherited from the parents or a new gene defect in the developing fetus. And when we talk about genetic types of hearing loss, we categorize it into a syndromic type of hearing loss, which might be associated with other abnormalities, abnormal ears or ear canals, abnormal kidneys, abnormal craniofacial problems, cleft palate. And those children are the ones that, when they're born, we see these obvious findings, what might alert us to potential hearing problems. But then the non-syndromic kids are an even riskier type of a group, because these are children who don't have any abnormal findings. About 50% of children who are born with hearing loss have some kind of a genetic problem. And within those kids, most of them are the non-syndromic kids, which kind of gets us to the next part of the talk, which is identification of hearing loss. And that brings us to newborn hearing screening. More than 90% of babies born in hospitals in the United States are subjected to a newborn hearing test. If we don't identify a child with significant hearing loss, the cost of that child through the course of his or her lifetime for our society in dollars is roughly $500,000 per child with hearing loss. The newborn hearing screen is either an otoacoustic emission, which is a fancy hearing screen terminology, or what's known as an ABR type of a test, which is done before the child leaves the hospital typically. If the child, before they leave the hospital, fails the newborn hearing screen, they're sent to an audiologist for a follow-up hearing test. Auditory brainstem response testing, it's basically an EEG for hearing, where a click is provided through an earbud to the ear, one ear at a time, and then through stickers on the head, we essentially identify the electrical impulse as it's transmitted from the ear to the brain. And then there's the classic pure tone audiometry, which is in the school system, the headphones at the desk, raise your hand when you hear the noise. And then the sound booth testing. It's useful to know at about a year of age, your child certainly should be babbling and repeating sounds, but at about a year of age, you should have a handful of clearly spoken single words. As a child hits 2 years of age, they should be able to put a couple words together. By the time a child hits 3, the vocabulary should be hundreds of words, and they should start putting more words together in growing sentences. But not only is there speech, but there's language and there's the understanding. And so can your 1-year-old follow a simple command? Can your 1-year-old point to his or her ears when you say, "Where's your ear?" So that gets us into what we do about hearing loss once we've identified it, so treatment and rehabilitation. Middle ear fluid, otitis media, we treat that with antibiotics, with removal from risk factors such as secondhand smoke exposure, daycare exposure. These are independent risk factors for ear infections, which can lead to hearing loss and speech and language delays. Acid reflux has been shown to play a role in the development of ear fluid and middle ear infections, and questionable relationship of allergy to middle ear fluid and ear infections. And how we treat this, other than with modification of these risk factors and use of antibiotics, are ear tubes, as a lot of you are aware. So that comes to hearing aids and how a hearing aid works. The hearing aid has an external portion which has a microphone and a sound processor, which basically is programmed for the individual patient's type of hearing loss. And the way the hearing aid works is it basically amplifies the noise. It turns up the noise where it needs to be turned up for a particular patient. Baha is trademarked from the Cochlear Corporation, but basically it's for conductive hearing loss and also for unilateral, one-sided, severe profound sensorineural hearing loss, deafness in one ear. But basically the way it works is that there is a sound processor which receives the sound just like a sound processor on a hearing aid does, but instead of amplifying the noise, it creates a vibration which sends that vibration through the scalp in an infant, okay, to the bone, to the inner ear. And then that sends the sound through along the normal hearing apparatus and the cochlea to the hearing nerve. After a child reaches about 5 years of age, okay, they no longer wear a headband holding that sound processor on, but we can actually implant a small screw with what's called an abutment, which is a titanium piece that sticks out from the skin that we actually attach the sound processor to. Cochlear implant is for sensorineural hearing loss for 2 ears, okay? People who can't hear a lick, even with hearing aids, or who can hear something with hearing aids and maybe will be able to perceive sound, but are not really acceptably perceiving speech. What we do with a cochlear implant, it's truly a miracle, is we provide an electrical impulse directly inside the cochlea to stimulate the nerve. That's achieved through an operation where we implant what's known as the receiver stimulator under the skin, and we drill out the bone behind the ear to get access to that inner ear, that blue part on the model, and we make a tiny little hole in the inner ear, in the cochlea. Under a microscope, we thread it into the cochlea. And then there's an external sound processor, which looks like kind of a bulky behind-the-ear hearing aid, much smaller every year. And that's connected through a magnet, a coil, which takes the sound which has been made into an electrical signal. It transmits it through the coil, directly through the skin to the internal component. It's got a microphone on it. It captures the sound through the microphones. And there's sophisticated electronics and software that's involved to program this sound processor to his hearing loss. Exactly what he needs. Identify it early, figure out what type of hearing loss it is, what it's coming from, and then plan our strategy for early intervention and treatment and follow-up after that.